My name is Peter Leedman. I'm the Director of the Harry Perkins Institute of Medical Research, and it's a great pleasure to welcome you all to what will be a wonderful and superb evening where you can hear from an outstanding academic about his research. But first, it gives me great pleasure to introduce Matthew Maguire to the lectern. Where's Matthew? There you are. Who's going to do our Welcome to Country. Just a little more background about Matthew. He's an owner-operator of a business for the visually impaired, a traditional owner of this land, and what a wonderful welcome to country. Very different and very memorable. Thank you once again. So just a couple of other acknowledgements tonight. There are a number of the Perkins board members here, including the chair, John Barrington, Val Rubenheimer, Belinda Murray, Roger Port, Yannick Spencer and Tim Colmer. So I haven't seen everyone yet. And I did see Katrina Stratton, there you are, Katrina, who's the local member here, and basically the rest of you are all distinguished guests. Now, we hold this oration every year, pandemic willing, to remember an incredible man, Mr. Harry Perkins AO. And it was his vision and commitment that led to the establishment of this entity, which was called, and it was always a mouthful, the Western Australian Institute for Medical Research, or WAMR. And he was the inaugural chairman of WAMR from 1998 to 2002. He was a farmer from Bruce Rock, and enjoyed an incredibly distinguished business career, as many of you will know, and he was chairman of Wesfarmers for 16 years. He would, I think, be extremely pleased with what WAMR Perkins is now. We have over 300 medical researchers and their teams from around the globe investigating lots of diseases and coming up with innovative ways of treating and diagnosing them. We've got 3 key programs, one in cancer, one in diabetes and cardiovascular disease, one in genome biology and genetics. And I won't go into those in any more detail at all because we've got lots of things to talk about tonight. But year on year, we're bringing and recruiting people from around the world. We're also retaining some of our best talent who often get lured to the eastern states or Europe or the US. Our award-winning clinical trials facility, and there are some of the board from Linear here, Fiona Harris, I'm not quite sure who else is here from the board of Linear, but it's a fantastic wholly owned subsidiary of the Harry Perkins Institute, and it's just going from strength to strength. A few weeks ago, we opened a 24-bed extension up in Joondalup, and next year we will finish off an extension downstairs from where Linear is on the first floor of B Block, which will be a 16-bed/chair devoted cancer early clinical trials facility, which is very exciting for the town. During COVID, most clinical trials facilities in the world stopped, early phase clinical trials facilities testing drugs in their first iteration. Linear not only stayed open, but it grew, and it grew incredibly and continued to have life-saving new medications here for our population in Western Australia to be given, and on occasion it was making an incredible difference to these individuals. So all power to Linear as it grows. We have a Lottery West Biodiscovery Centre. I'm not quite sure if you know about that. It's a wonderful centre. We have thousands of students, literally thousands coming through every year. And that's continuing to grow as well. So school students and Probus clubs and Rotary clubs, but predominantly school kids, benefit greatly from our investment in our biodiscovery laboratory. And we treasure our donors and supporters and volunteers, and more than 2,000 people were involved either in our walk or our ride that we had about 3 or 4 weeks ago. And some of you will remember that was the best ride ever. It raised, and that was because there was about a 30-kilometre tailwind southerly that came in at about 7 o'clock, it seemed, but it wasn't 7, and it blew people back to Perth incredibly well. And then there was a little wander into the campfield for some refreshments. But that raised $8.6 million, and that's from the community. All of these things I've just mentioned would warm Harry's heart. I had the good fortune to get to know him a little bit in the years before he died. And he would be most pleased with our science, the innovations, the discoveries, the translation of those discoveries into new diagnostics, therapeutics and preventives. And I'd just love to be able to share that with him now. But in that breath, it is a pleasure, great pleasure, to introduce one of Harry's daughters, Dr. Jane Allen, who's with us this evening, a great supporter of the Perkins, a many times Walk for Women's Cancer walker, with her daughter, Hannah, who's also a walker. So it's a great pleasure to invite you, Jane, to say a few words about your dad.
Thank you, Peter, and good evening, everyone. I have the almost impossible task of conveying some of the essence of the person Harry Perkins to you tonight. When I'm asked how Dad got involved in medical research, I take a big breath and try to explain some of the foundation stones as to how a farmer who finished school in Year 10 ended up helping to establish this place. And it wasn't just him. He had a fabulous team around him, Peter Klinken, all the researchers, and Dad would always take his hat off and say, it's not me, it's everyone around me, and all the other benefactors that helped in those early days and today. As Vice President of the Council of Bruce Rock Board, Dad realised that having a local doctor dictated the health of the town, both as an individual and as a community. In later years, he saw that translating to a vibrant medical research in Perth gave us a vital, healthy West Australian population. He had a long history of collaboration, starting in farming cooperatives. I well remember the neighbour coming and comparing rainfalls so that Dad knew what the rainfall was on this section because it was closer to their household. It wasn't just him. He worked with other farmers discovering new techniques. He then moved into the CRCs and he was chair of the CRC for Mediterranean plant legumes. And then finally, Weimar. Along the way, he became chairman of Wesfarmers, chaired CRC, and then the board that oversees the CRCs was Chancellor of Curtin University, and a host of passions that range from sport to education to rural communities. These all laid the foundations so that when the two Peters asked for help in establishing Weimar, Dad could respond. Dad said to me on more than one occasion that he did not have a problem, just a difficult decision to make. This change in perspective, by changing the problem into a decision, meant he moved to action. That action would often involve drawing in a team that would work together for the greater good. Part of this action is about giving hope, something that Dad saw as vital to life. Hope is being positive in whatever situation you're in. not blind optimism, but defeat of deadly pessimism. It is this belief that is the very basis for human motivation. We can work towards the type of future we want to live in, and Dad lived that vision. I trust that tonight, Professor Alex Brown will give us some insights into the decisions that we as a community need to make to give us all hope for a healthy future. Thank you.
The tragedy is that Harry died about 3 to 4 years before the drug that might have helped him was actually available. So he died of lung cancer, but he was a non-smoker, and there were new drugs developed about 4 years later that may well have saved him. And that's very unfortunate. All right, while we're sitting here in this magnificent auditorium, I'm acutely aware, and some of you will know that I still work as a doctor at Royal Perth and have done for a long time, that there are incredible discrepancies in the community between the levels of healthcare that get delivered. There are people who succumb to diseases at a higher rate than others, and whole access to treatment and healthcare can be lower in various socioeconomic strata. So physical, socioeconomic, cultural and political factors and the availability of health services, they all impact on people's health. And sadly, inequity plays a very significant part in some parts of this country, and that's what we're going to hear from our guest speaker tonight. And so Professor Alex Brown has an extensive and well-established and unique research program, and I really say that with great understanding. And he's been focused on chronic disease in vulnerable communities, predominantly the Indigenous communities. And you want to make a difference and are making a major difference. He's internationally regarded as an Indigenous researcher. He's a medical doctor, medically trained, and originally from, Alex, if I understand correctly, the Yuin Nation from the south coast of New South Wales. He's now the Indigenous Genomics lead, and so he's a professor of Indigenous Genomics at the ANU and TKI, and he lives in Adelaide, so it's complicated, but he's on a plane almost every week between this triumvirate. He's recognised for his amazing work in heart disease and in Indigenous health, in the provision of public health services, infectious diseases, chronic diseases care, healthcare policy and research. And he's one of the very few people who can go from a clinical problem into government, into policy, and start to enact those things. It's really hard to do and very challenging indeed. His PhD on depression and heart disease in Aboriginal men tells a great deal about his deep awareness of the complex influences on health and well-being. He's played a major role in setting the agenda in Indigenous cardiovascular disease management in Australia through his influence on health policies. And interestingly enough, after completing his training in medicine at the University of Newcastle and working in Central Coast of New South Wales, you went off to Israel to do a Master of Public Health. You came back and spent 14 years in Alice and loved it, and you were very involved in all aspects of Indigenous health there. I got to know Alex when we were on either side of an interview table, and I was the chairman of the Sylvia and Charles Viertel Foundation, and Alex was an applicant. And this is a set of fellowships that we award to the best mid-career researchers in Australia, and I mean the very best. And you interviewed incredibly well and was successful, and that was a springboard for Alex in his career. Of course, we predicted that he would be a superstar, and he is and has become a superstar as a consequence of that. He sits on a range of national committees, co-chairs Indigenous research health funds, and is a very well-known identity in all aspects of Indigenous health. So please welcome Professor Alex Brown to the podium. He's going to tell us, the title of his talk is Overcoming Indigenous Inequality, Tales of an Aspirational Pragmatist.
Well, wow, what an introduction. Thank you, Peter. I hope it wasn't too long for you all. And now that he's said everything, we can all go and have another drink. Firstly, a couple of housekeeping matters. I can't wait to get rid of these really big-ass pictures of myself. I'm feeling a little uncomfortable. So let's do that. But more importantly, I'd like to thank Mr. Maguire. It's a great privilege and pleasure to be on Whadjuk country. I pay my respects to the elders here, and also want to reflect how proud I am to be an Aboriginal Australian and to have the blood of the first people run through my veins too. So thank you. What I thought I'd do is take you on a little whistle-stop tour of the last 15 or 20 years of work. You may ask why I consider myself an aspirational pragmatist. When I read it out aloud, looking at that big slide of my ugly head and the title, I thought it sounded a little bit weird and self-absorbed. My apologies for that, that wasn't the intent. But I've always been a very, very aspirational person, but one who's willing to make the hard decisions and compromises when necessary to get to that outcome. And hopefully I'll reflect a little bit of that story over the next little while. So many of you would know that Aboriginal and Torres Strait Islander Australians are disproportionately burdened by illness, poor health outcomes, socioeconomic inequalities. The reasons for this are broad, complicated, and often difficult for communities to understand, and it's certainly very difficult for governments and bureaucrats to respond to. We know there's somewhere between 800,000 and 1 million Indigenous Australians spread right across the country, overrepresented in remote and outer regional areas. But we have very large populations in virtually every large community across the nation. We represent now about 3% of the Australian population. And one of the truths is that we are different, that heterogeneity is the truth and reality of Aboriginal and Torres Strait Islander Australian. Different languages, different customs, different ways of knowing, but a deep-rooted connection to place and each other would be the way in which we would describe who we are as a collective. Now, what population health people tend to do is look at what populations look like, and you can see very distinct differences between Aboriginal and Torres Strait Islander communities and non-Indigenous communities in this country. You can see on the bottom right-hand side of the panel, non-Indigenous Australians are now living very healthy, long lives. And the vast majority of when people pass is in their 70s, 80s, and now increasingly in their 90s. But for Indigenous Australians, this is not the case. We still have this bulge or this middle age spread of mortality at a time when people should be their most productive, their 40s, 50s and 60s. In fact, the vast majority of Indigenous Australians still pass away before their 65th birthday. And it is this sense of inequality that really triggered our program of work to try and understand why this occurred and what in God's name we were going to do about it. Where do we start? If you want to know why we see this particular pattern of premature death in Aboriginal and Torres Strait Islander communities, have a look at what causes people to pass away. And we see this very strong signal from chronic diseases occurring at 10 to 20 years earlier and at extremely high rates in Aboriginal and Torres Strait Islander communities. And in fact, if you would decompose, which is an epidemiological term rather than a mortality term, you would see that these chronic conditions like heart disease and diabetes and cancer and kidney disease account for about 80% of the life expectancy differential that we see between Aboriginal and Torres Strait Islander people and the rest of the community. a life expectancy differential which is profoundly problematic and on every level completely unacceptable. So we wanted to know how to close the gap. We needed to decide what gap it was. In this instance, it was life expectancy. We needed to understand what drove that gap. It's the chronic disease story. So I'm not a failed cardiologist. I chose another path. Anyway, we can talk about that later when we debrief and psychoanalyse me. So what do we know about the leading causes of death across ages for Aboriginal and Torres Strait Islander people? Well, unlike what you would see in non-Indigenous communities, chronic diseases start to bite at extremely young ages. Here you can see in the 35 to 45 year age group, the middle of the top panel, the leading cause of death for Aboriginal and Torres Strait Islander people is actually coronary heart disease or ischemic heart disease. This is not a disease we see at high rates and driving high burden of disease in non-Indigenous people until 20 years later. So for it to be the leading cause at such a young age signals that there's something amiss. We then see in the 45 to 54 year age group, diabetes and cancer start to loom large as key drivers of mortality at extremely young ages. There's a question of what are the big three that we need to be thinking of. Surprise, surprise, it aligns very strongly with the Perkins agenda of cancer, cardiovascular disease and diabetes. And increasingly, I'll touch on a little later about how we can use advanced technological approaches to try to understand and overcome this through genomics. I mentioned this very clear pattern of difference. We see this in the context of cardiovascular conditions as an archetype of inequality. And here, this is data from South Australia comparing the proportion of deaths that occur at different ages between Aboriginal people in South Australia and the rest of the community. And you would see that the vast majority of death from heart disease is occurring in Aboriginal and Torres Strait Islander people in their 40s, as compared to non-Aboriginal people in their 80s. This is a 4-decade differential, and something that we need to come to terms with. And there is some good news, but also some bad news. Over the last 15 years, we've seen a 60% reduction in mortality from cardiovascular conditions in Aboriginal communities, which is a great result. But we're barely keeping pace with the improvements that we see in non-Indigenous Australians as well. So the gap is either holding steady, or in the context of Aboriginal women here, in the 55 to 69 year age group, the inequality is actually widening. So it's one thing to look at how much is occurring and the rates of that it's occurring in certain population groups. It's another to compare what the markers of inequality are. In this case, the mortality ratio between one community and another. And that gap is widening. We've still got a lot of work to do. The other thing I mentioned was the impact of diabetes. These slides' data's a little bit old, but I can tell you that in fact, if anything, these inequalities in the prevalence of diabetes in Aboriginal communities compared to everyone else have gotten markedly worse. You can see extremely high rates of diabetes at all ages in Aboriginal people, and the inequality is extremely large again at young age. We're now starting to diagnose type 2 diabetes in Aboriginal children under the age of 10. This is not a whole bunch of bad kids behaving badly. These are fundamental concerns that we have about why we see inequitable disease across population groups. And whilst we may think that we've got the highest rates of type 2 diabetes in the world, we probably don't, but we're in the top 3. Where we lead all international league tables is the inequality in death as a result of diabetes in Indigenous Australians. So we not only have extremely high rates, we're not doing our job in the system to make sure that Aboriginal and Torres Strait Islander people are not dying as a consequence of their diabetes. And the real concern within the diabetes story is not just that people are running around with high blood sugars, although that's an important part of the story. It's the development of complications that drive particularly high rates of morbidity or sickness, as well as mortality. So the big ones we worry about is the impact of diabetes on the development of strokes. We worry about the increased risk of having a heart attack if you've got diabetes. We worry about high rates of amputations, which we see at 48 times higher in Aboriginal communities compared to non-Indigenous Australians. We worry about blindness, preventable blindness from diabetic retinopathy. We worry about kidney disease. We have extremely high rates of end-stage kidney disease in Aboriginal communities. 80% of it is driven by diabetes, and we're not doing anything near enough to prevent this complication. But there's also a whole raft of comorbidities as well, and what we mean by that is your bad cousins that hang out with you at the wrong times in your life. So it's not just the diabetes that plays, there's a whole bunch of other things that come along for the ride and are associated. High blood pressure, high blood lipids, fatty liver disease, which has now changed its terminology for the 8th time in the last 10 years, sleep apnea. All of these conditions are associated with or increased in prevalence in those with diabetes. So it's not just the sugar, it's a larger story well beyond that. We've also been doing significant work over the last 10 years or so to get a better understanding of what's happening in cancer in Aboriginal and Torres Strait Islander communities. We anticipate the next decade will be the decade of cancer in Aboriginal people. We're starting to see increasing rates and increasing mortality. It's now neck and neck with cardiovascular disease is the #1 cause of death for Aboriginal people. It's more advanced at the time when it's diagnosed in Aboriginal people compared to non-Indigenous patients. There is a burden or an impact or a cost of remoteness. The further you are away from metropolitan settings and access to high quality tertiary care, the higher your mortality. We tend to suffer from highly mortal types of cancer, the ones that are particularly associated with lung, head and neck cancer and liver cancer. We have higher rates of the risk factors which drive the development and poorer outcomes from cancer. We're less likely to get screened by the systems that exist. We have higher rates of comorbidities, these unhelpful friends that travel along. We get less treatment, our survival's worse, and unfortunately our mortality once diagnosed is much higher and much quicker. So we spent some time trying to understand what was happening in South Australia. And over 30 years of looking at the data that existed, we found a tripling in the number of cases of cancer in Aboriginal and Torres Strait Islander people here. This data from 1977 through to 2010. But unfortunately, what we didn't see is an improvement in outcomes over that same 30 years. What we see in non-Indigenous Australians in South Australia, over that 30-year period, their survival after developing cancer had markedly improved. For Aboriginal people, this was not the case, despite 30 years of medical advance and our ability to identify and treat cancer much better. So the inequalities were not only in existence, they were embedded and unfortunately remain a major concern for us. And what's on the horizon? Well, unfortunately, it doesn't look great. Modelling would suggest that the rates of chronic disease, particularly the heart disease, the diabetes, the cancer story, are likely to increase significantly over the next 10 or so years. So then that begs the question, well, what the hell's going on here? How do you get to the root causes of inequality? How do you understand what it looks like, what it feels like? How do you overcome it? Well, if you're feeling sad and depressed, you could be suffering from capitalism, although in a room full of donors, I'll be mindful of my P's and Q's. Sorry, Peter. Well, the truth is, inequality begins very early for Aboriginal and Torres Strait Islanders. That's the truth of it. That's the painful reality that we face as Aboriginal people every day and that our communities have faced for generations. And you'll look at the left-hand side of this panel and say, oh, well, you know, there's some differences there in child mortality. Infant mortality rate over time has improved significantly for Aboriginal people. You look at the data from South Australia in the black thick line and you would say, well, you know, we're tracking well. But if you scratch the surface of these differences, you would see that there are inequalities within inequalities. So the outcomes for infants, Aboriginal infants in remote South Australia are markedly worse than what we see for many other Aboriginal young people across the state at rates that we would see in low and middle income countries around the world. In fact, in some instances, much worse. And how are we doing in terms of looking after kids? Well, not great. How do we look in terms of making sure that every child has the best possible start to life? Are they on track? Are they ready? Are they growing? Are they getting the support that civil society should ensure that every child in this nation gets access to? Well, the answer is no, particularly if you're in remote Australia. And then you would wonder, well, what's community, how are they going? How are they travelling? Now, suicide rates are a blunt tool, but they do give you a read as an indicator on the health and well-being of communities more broadly. And you would see incredibly high rates amongst Aboriginal and Torres Strait Islander Australians. In fact, on one of the earlier slides, the 4 leading causes of death for Aboriginal people between the ages of 25 and 35 was suicide, self-harm and interpersonal violence. And why does this matter? Well, it matters, as all civil society should care about all of its citizens. But also we see very significant gradients across mortality for various causes that's patterned by a whole raft of socioeconomic indicators. So if we're not doing well in terms of providing the fundamentals for a child's start to life, how does that set itself trajectories for inequality through the life course for these children? Well, I can tell you, not only are there gradients in things like cardiovascular mortality, but those gradients are widening for both males and females, and we've got a lot of work to do. Similarly, we've learnt very clearly, this is data from North America, that there are intergenerational cycles that establish themselves in the context of chronic disease. This is data around type 2 diabetes. You can see data on the left side here, which talks to the chances or burden of type 2 diabetes in children born to mothers with type 2 diabetes during pregnancy. And you can see by the age of 30, about 80% of Pima Indian children born to mothers with type 2 diabetes have type 2 diabetes themselves. This is at an extremely young age. And this data has been replicated now in Canadian populations who have shown on the right-hand side in this top blue hashed line extremely high and inequitable development of type 2 diabetes in offspring of these mums. And now there's been further data to suggest that these cycles are compounded in subsequent generations. So the children born to mothers with type 2 diabetes in pregnancy are likely to develop diabetes before the age of 30. The other part is, well, socioeconomic factors obviously play. Most people have diabetes because they're fat and they eat too much food, right? Wrong. Poverty plays. And what are you going to do about it? Well, as a civil society, very little it seems. But what we know is that Aboriginal communities deal with the face of poverty every single day, right? And when you're dealing with the communities trying to work out how they're going to get the next feed, them taking their medicine is about 100th on the list of things that they need to do. And we as a system need to understand these realities. We asked communities, how long does your money run? How long does it last before it runs out? So almost a third of males and females in a large population survey we did in South Australia have run out of money within 3 days. And people often say to me, well, we give Aboriginal people so much money. I can tell you that the number of Aboriginal and Torres Strait Islander families living under the poverty line would make your hair curl. And we as service providers are trying to think about the best ways we can overcome the impacts of poverty in our communities. And it's impossibly difficult. Similar data from South Australia. 30% of Aboriginal people in the country ran out of food in the 2 weeks between pay cycles, compared to about 3 or 4% in non-Indigenous communities in South Australia. And say, oh, well, poverty's really bad. Not only is poverty really bad, if you're food insecure, your chances of developing type 2 diabetes over the preceding few years is markedly increased. So poverty bites on multiple levels. And then we wanted to know whether or not these impacts have broader consequences for health and well-being. This was part of my PhD work that Peter mentioned during his very long soliloquy, introducing me. Thank you, Peter. And what we did is we asked a whole bunch of Aboriginal men in Alice Springs, what's their day-to-day life like? 30% of men couldn't get a good night's sleep ever. 30% of men couldn't get support when they needed it most. 30% of men experienced racism every single day of their life. 50% of men lived in a high-stress environment and they didn't know what they were going to do about it. Now say, oh yeah, well, that's really tough. Yes, it's tough. Not only is it tough, if you're experiencing such hard and profoundly difficult times, you're much more likely to be depressed. If you're depressed, you are 10 times more likely to have coronary artery disease. Now, this is not cause and effect because we're only looking at one point in time. We're not saying that stress and worry drove their heart disease. We're simply not saying they got heart disease and then became stressed. We can't tell which way that relationship goes. But if we're not thinking about the health and well-being in a broader sense of Aboriginal people, and everyone else for that matter, we're not doing our job properly. Poverty bites. Stress and worry and grief and loss has an impact. And what's our response? I can now openly use this slide. It got a little bit testy when I first started using it when he was still in power. The policy response to chronic disease in Aboriginal communities has been an absolute abject failure. Now, I'm not suggesting that the national policy context is framed around these sorts of thoughts, but they are profoundly influential. We're talking about chronic disease in Aboriginal communities. The response was from the then Health Minister, Indigenous people should eat better and exercise more. And in true Trumpian fashion, before Trump was even in the picture, Mr Abbott had somebody come out and say, well, I think what the minister was saying was, well, everyone can afford a pair of sneakers, get out there, right? This is our policy context and our policy response to dealing with inequality. And even when we have policy, like the Close the Gap agenda, which is extremely important, if you were to give it a test of how well it's achieving its target as a policy imperative across the country for reducing Indigenous health inequality, how are we doing? Pretty poorly. We're getting better on early childhood education. Our Year 12 attainment is better across half of the jurisdictions in which this is adequately measured, but the rest aren't doing so well. So even when we get a policy context right, we're not enforcing or enabling or resourcing the response that's required to achieve the outcome that we hope for. So say, all right, Alex, stop bleating, stop carrying on. What did you do about it? Well, we did a whole bunch of stuff. Can't even cover all of it, but I'll give you an idea. What we built was a team. Our first step, build a team, engage with communities, understand our role as researchers. We're critical to not just do research, but to make an impact across all of the people, all of the stakeholders who had a role to play in reducing inequality for our communities. We spent a lot of time myth busting. You know, aren't Aboriginal people getting too much money? Don't they all get free cars? Right, that old chestnut. I went through high school hearing that, thinking, man, you've got no idea how beat up my dad's Valiant is. 1969, hole in my phone, you know, where's mine? I'll have one, thanks, that'd be great. We spent a lot of time with communities about what mattered to them the most, what were their priorities. We developed Indigenous governance of the research that we wanted to do. We tried very, very hard, and I would think successfully, to change the culture of the institute in which we were working to understand that Aboriginal business was core business for everyone, not just the subunit of brown folk sitting down in the basement doing their Aboriginal stuff. And we knew very clearly that if we were going to do research, it had to be translated. We had to make sure that that information changed something, influenced something, whether that was policy or practice or the way in which people understood the world around them. That was our job. I mentioned that our foundational steps were engaging with community. This is what we did. we asked communities what mattered most to them. In fact, one of our questions, working right across communities in South Australia, was to ask them what keeps you up at night. What's your biggest worry for you, your family, or your community? And that became the research priority agenda for our research. Not only did community tell us what mattered to them, they told us how we had to behave. And we built the Aboriginal Research Accord for South Australia, which stipulated the terms of engagement between Aboriginal communities and us as researchers. And slowly we built an Aboriginal workforce. Initially, it was hard. All of the non-Indigenous people I employed understood very clearly their job was to put themselves out of work. That's a very hard conversation to have, but it's one that we had openly and directly. Their job was to find their own replacement and train them, and they did it. We spent a lot of time growing the next generation. Aboriginal and non-Aboriginal PhDs working directly in Aboriginal health, MPHs, Masters of Applied Epidemiology, graduate certificates in public health, honours programs, advanced MD programs, whatever it took, wherever these Aboriginal and non-Aboriginal students were at, we found a path, we found a way, and we supported them to make their contribution in a safe and culturally aware space. We built complicated but community identified and endorsed research programs. This is the Central Australian Heart Protection Study. It didn't last with that name very long. I went to community and said, hey, we're going to do the Central Australian Heart Protection Study. And they said, well, what does it involve? I said, well, it's about learning about your heart, looking after it, keeping it healthy, and engaging the family. This was a secondary prevention, that is, after a heart attack prevention program for Aboriginal and non-Aboriginal people in Alice Springs. And they said, oh, that's a stupid name. And I went, oh, you got a better one? And they said, yeah, Chukura Maraka. I said, oh, what's that? Healthy heart. Oh, okay. That sounds pretty good. We'll take that. And this is the painting painted by Marie Ellis for us to explain the burden that Aboriginal women carry for families and health, holding the heart and everything else in communities. She's a very strong feminist. And if you build intervention trials with communities, look what can happen. We reduced mortality for Aboriginal people by about 50%. In 2 years after a heart attack, our initial data was suggesting about 40% of Aboriginal people were dying after a heart attack. It was worse than some cancers that we see in terms of survival. You build an intervention with community their way, you can overcome inequality. In fact, we generated inequality. The data was so good in Aboriginal families that non-Indigenous families couldn't keep up with the benefits that we were able to demonstrate by building it with communities their way. We built advanced epidemiological and integrated systems of data to support policy decisions in cancer across all of South Australia. We wanted to develop and ensure that the registry data was comprehensive. We wanted to link that to the data around the services that were provided and the outcomes that were delivered. And we wanted to ensure the voice of communities were embedded within this data system. So it wasn't just information or numbers, it was narrative, it was reality, it was experience. This is very good, not just for providing data, but providing the context around which those inequalities were experienced and clarity around what we needed to do. This understanding has built really important models around how to do things better, not just for Aboriginal people, but for all of society, for all of communities, about how we need to do better as a healthcare system to care about the health of our patients and support the development of health through our care over the years to come. We not only did research in diabetes, we were very interested in the complication story. I touched on that before, the development of kidney disease in diabetes, whether or not people would develop blindness or cardiovascular disease. We knew we had a bigger job to fulfill. We had to build a workforce. We had to train them. We had to focus on the root causes like the social determinants of health. We had to ensure that services were built, operated, evaluated, tweaked and improved to make sure that we could deliver as a healthcare system to what communities demanded, or if they didn't demand, they damn well should have. And that relates to the development of renal services, diabetic foot care. We now run a national program right across the top end of the country, and the development of eye care services in Aboriginal communities as well. So, was this successful? Not enough. There's more work to be done. The question is, given my new fancy title as the Professor of Indigenous Genomics, how I got that gig, I don't know. That's okay, we'll work it out. I've got good friends who are really smart at genomics who are going to help me. Some are sitting in the room. Can it be used to reduce inequality? Well, the concern is that if you bring in any advanced technology, it always benefits non-Indigenous or the advantaged preferentially. And it can drive a wedge further between communities that have and communities that do not. So there's a role for us to play in understanding how genomics operates, whether it can account for the inequalities we see on some biological level, but probably more importantly, how do we engage communities in things like genomics? How do they become our strongest supporters, our strongest allies in making sure that the best possible technological solutions can be applied to the needs of all in an equitable fashion, which means according to their need. So, do we make sure that Indigenous people just have access to genomics? Or do we make sure that everyone can access the genomics and other technologically advanced medical care that they deserve and they require according to need? That's the difference between equality and equity. That's the importance of making sure you understand your communities and what they want and what they need. So why do we care about genomics and genetics? The vast majority of interest is trying to understand what variation between individuals occurs, likely due to the development or impact it has on disease. So we look at whether or not a person with diabetes has a different code in their genes compared to people who do not. The challenge is complex diseases like heart disease, like cancer, like diabetes, the three most important drivers of life expectancy differentials for Indigenous Australians, are really complex, and most people have lots of variation. So the question is, how do you make sense of that? Well, I don't. I employ really smart people to help me make sense of that. Where did we get involved in the genomics story? Well, I mentioned before our concerns around diabetes and diabetic complications. We were approached by communities who had been approached by genetic researchers about understanding where they came from and how long they've lived in Australia. The answer was pretty clear. Indigenous Australians have been here for pretty much ever. 65,000 years, 70,000 years, 80,000 years, throw a number here. How long does it have to be until you'll all accept that we've been here for as long as anyone else has been anywhere, right? Not a bad continuous survival agenda. Not a bad story of surviving through adversity and understanding what it takes to live on a continent like Australia. But they weren't interested in that story. They said, sure, we know we've been here forever. What are you going to do about diabetes? And so the genetic researchers said, oh, I don't know, we'll ring someone. They rang someone and they said, oh, this community is interested in diabetes and genetics. And the other person said, well, how many people do you need to be involved in a study? And they went, oh, thousands. And they went, oh, you need to ring Alex. So I got the call. And we were already really concerned about the diabetes story. The inequitable burden, this very premature onset that we saw, the very aggressive, what we would say, phenotypes, so the chances of developing a complication, eye disease, kidney disease, heart attacks. And then the story that I touched on before about this intergenerational transmission. The question is, can genomics help us unpack this story in some way? Can we make sense of why these things occur at particularly high rates in our community? Together with communities, we built a project, a longitudinal study that we were going to track Aboriginal people in South Australia from all the communities there. And we were going to understand not just who develops complications, but we were going to trace back at all levels of what genomics has to offer, not just the gene story and the code written down. We wanted to understand how those genes were influenced to function or not function, to be turned on or turned off, what those genes told the cell to make in terms of proteins, and then what happens to those proteins and what's left of them, that's remnants within the body. We can measure all of these things. The question is, can we make sense of it in a way that helps us to understand those fundamental questions? This study, now 7 years in, after 3 years of consultation with community before we even began, we've recruited just under 1,400 people. We've got information that will enable us to understand all of these various layers that genomics and advanced technological scientific endeavours will enable us to explore, and we can apply this to understanding why certain things happen to certain people. So this heralds the story about whether or not Aboriginal and Torres Strait Islander people will get something out of genomics more broadly. Well, the potential is large. If not done well, it will not do anything of the sort. If it has not been well handled, if it's not engaged with communities, it will drive inequality further, and that's our major concern. But we know that it has potential. You can use precision medicine to unlock the benefits of genomics. You can develop biomarkers that tell you, just like a blood test, although a little more complicated, who's going to develop trouble into the future. You can then use that information to identify the right treatment to the right patient at the right time, which is what medicine's all about anyway. We've just got some machines that go ping and cost a lot of money to run. But importantly, it's not just about being able to diagnose or get the right treatment. It's also about how we can utilise this information to better prevent disease developing in the first place. And if we don't apply the precision medicine agenda to the prevention story, we're not doing our job properly. We know that precision medicine has a role to play in cancer. We know that there are genomic correlates or genes associated with the development of various cancers, and we know that there's some genes that are associated with the development of lots of cancers. So we should be able to use this architecture of research and clinical care to get better outcomes for all. We also know that we can look at all of these layers. This is a multi-omics story. It allows us to measure the causes and consequences of a great range of things, of clinical patterns or phenotypes. We should be able to use this information to better connect what someone's genetic story is, as well as the broader story. And it should, if we do our job well, provide a much more holistic sense of health and well-being and the reasons for disease developing over time. But we've still got a long way to go. We know that there is a role that precision medicine could play in diabetes. Not just about the appropriate diagnosis or working out the right type of diabetes that a person may have, whether it's type 1 or whether it's a monogenic form or gene form of diabetes, which is uncommon but still in play, or whether or not it's much more commonly the type 2 diabetes story. You can use molecular techniques to better understand. We should be able to use it to develop tools that help us predict the risk of certain individuals developing disease and complications, and we should be able to identify more targeted treatments with less side effect profiles. But there's work to be done. And as it currently stands, the genomics story around the globe is largely for Europeans. So 80% of all of the studies that have looked at various groups of diverse ancestry or background, 80% or thereabouts are Europeans. So what does this tell us about the world in which we live? It tells us that we've got a lot of work to do to make sure that the genomics world represents all of humanity in all of its forms, not just the privileged in North America and Europe. And the challenge is, most of the conversations we have with these international players is, well, we'll just include a few brown folk in our databases and that will deliver equity. Wrong. Inclusion does not equal equity. Empowerment, agency, engagement, targeting priorities of communities, building a workforce for the future that is of Aboriginal and Torres Strait Islander people to ask these questions themselves and answer the damn things, that's equity. We can be in your databases, but it's not enough. So what could we think of that might be the benefits that genomics could offer the world? What could it offer Indigenous Australia, particularly in the context of chronic disease? It should enable us to tell our story, where we're from, who we are, and why we were so damn successful at living for 65,000 years in one of the harshest environments on the planet. It should build the right terms of engagement and build trust between communities and the scientific community about how to do stuff properly. It should be able to help us more accurately diagnose disease. It should help us develop precision treatments and algorithms to predict risk. It should help us build a workforce of the future that's made up predominantly of Aboriginal and Torres Strait Islander people. It will force us to control data wisely, securely, and appropriately according to the rules of engagement that Indigenous people themselves define. It should help inform equitable policy, improve access to care, but more importantly, it should reduce inequality if we do our job. Now, most people would say, what has genomics got to offer Indigenous people? I would further posit, what do Indigenous people have to offer genomics? We are extremely valuable people on this planet, and we offer very unique gifts. A gift of welcome to country. Now, white people don't do that. Aboriginal people do it really well, right? And why do we always invite them? It's the right thing to do. But it's also about a deeply rooted sense of connectedness to people and place. It's a very, very important part of who we are. But we've got more to offer. We've got to offer ways of doing this the right way. We can offer ways of understanding context more broadly than just, hey, you're a diabetic who's too large and eats the wrong food and won't take your medicines. There's a bigger story at play, and we can offer some of those solutions. So what are we doing? Surprise, surprise, we start by building a team. Not only that, we start by understanding what communities' priorities are. And we're leveraging this to the application of how genomics can make a difference in Aboriginal and Torres Strait Islander people's lives. We have work around providing national leadership to do this the right way as best we can. We have the chance to develop multi-omics and understand this in the context of these chronic diseases we touched on. We have a chance to apply the opportunities that precision medicine and precision health offers to the inequality faced by Aboriginal and Torres Strait Islander people. And we can use the depth of genomics to understand this very important nexus between people and place and the health of both. We are leading programs of work across the country in empowering communities in genomics as an important first step. To build an understanding of what Aboriginal and Torres Strait Islander people understand about genomics and inheritance and survival. We've clearly got work to do in building capacity around data sciences for ourselves and for our Aboriginal and Torres Strait Islander community partners. We've got methods to build around multi-omics. We've got lots to understand about what makes us unique and different as Indigenous peoples in terms of the genomics story. And we've got to collaborate widely. We've got to build capacity. We've recently been funded to establish a national network in Indigenous genomics. We'll establish it. We're going to enhance communities, in particular, understanding of what genomics is. We're going to identify the critical policies that matter to make sure this is done the right way. We're going to define, share, and support the development of best practice approaches to this. We're going to build a workforce of the future. And we're going to make sure that genomics delivers a damn benefit to our communities. Otherwise, it's not worth doing. How it looks, we'll have jurisdictional nodes right around the country who will be expected to develop Indigenous governance mechanisms, identify key policies in genomics, build data systems, and build capacity. And then what we want to understand is how could we use genomics to deliver benefit directly to communities, whether that's in pharmacogenomics or understanding how certain people respond to drugs, what does precision medicine need to look like from an Indigenous perspective, etc. How do we make sure we develop a roadmap that ensures genomics delivers something? So in that whistle-stop tour of everything, and the universe and the number, I don't know, whatever it is, what have we learnt? Thank you. Research without understanding context is wasteful. It's wasteful in the context of marginalised communities who are experiencing profound inequality and who have historically been screwed over. If you don't understand context, go and do something else. It's okay, we'll find some other people. Our ability to connect to one another and care for one another is the fundamental pursuit of life. You see this writ large in communities who face significant inequality and suffering day in, day out. You learn that those with the least give the most. It's the reality of my engagement with Aboriginal communities right around this country. And it's at the margins of societies, these town camps, these fringe dwellings, these communities pushed to the edge of large civil communities. That's where human spirit endures. That's where it means something. That's where people will take a bullet for one another, in a metaphorical sense. If there's any lesson to be learnt, don't be obsessed with the things you can't change. This is Aboriginal health writ large, right? This is Aboriginal policy and affairs writ large. Don't be obsessed by the stuff you can't change. Be driven by what you can, because changing the world needs a really, really good strategy. Be resolute but not stubborn, and the difference is really important. People who apply stubbornness to a solution will never change their course. People who are resolute will never give in, no matter how hard it is and how many times they have to change their strategy. Never give in. Your integrity depends on it. And importantly, where injustice lives, you're up. It's everyone's business. It's never someone else's job, it's yours. And remember, although we have been successful as Indigenous people, surviving through all adversity, it does come at a cost, and a cost borne by my families, my ancestors, my communities. And lastly, we need a lot of help. There's a big job to do, but if you're not going to help, get out of our way. We've got a lot of stuff to get on with. Thank you very much.